Hi friends, good evening. I'm Dr. Ashutosh Gupta and I'm a consultant fetal medicine. So today we are going to talk about the factors that really govern the growth of the baby. Okay, so whenever we do the any ultrasound, that ultrasound has got an error rate of something around 7% as far as the biometry is concerned. So meaning thereby that the accuracy of the ultrasound as far as the gestational age of the baby is concerned, it is most accurate when we are doing the ultrasound at something around 7 weeks. So 7 weeks plus minus 7% error, it turns out to be something around 1 day, right? So this is one of the pregnancy that probably we were following, and then we saw that the patient was being there at the anomaly scan, right, at the level 2, which is at 20 weeks, right? And then we identified that from the previous two ultrasounds the baby should have been 20 weeks and plus, meaning there were 20 weeks and 1 day and 20 weeks or 3 days, right? So never ever the baby was short. And on the biometry that we were doing, it was turning out to be 18 weeks, 18 weeks 1 day at max, right? And then the abdominal circumference was even lagging behind. It was 17 weeks and 3 days. So there could be a lot of factors that probably we can try to look around for why the baby is not growing, right? So that could be uteroplacental insufficiency. That could be some sort of a genetic abnormality to the baby, and therefore the baby is not growing. Or there could be some other factors, right? So, but during the scan, the anomaly scan, we picked up one small finding, and then that probably could lead to this whole scenario that the baby is lagging behind in the growth. So this is I'm going to explain in this video today. Look around here, the baby should be 20 weeks, but the baby turns out to be only 18, right? And then the uterine arteries are normal both on the right hand side as well as on the left, right? And then we try to look around for the umbilical artery flows, and the umbilical artery flows are absolutely, even though the baby is growing, showing a growth lag of 2 weeks, but the umbilical artery flows is normal, right? And then this is a small finding that probably we picked it up. So this is a but this is the fourth chamber heart. Okay, so try to look around closely. We identify that both it is a globular cardiac hypertrophy, right? And then we can identify that this is the right ventricular wall, left wall, interventricular septum. So both of them are globular cardiac hypertrophy, right? And at such a small gestational age, this could be infective. Most likely could be CMV, Coxsackie B19, or could be a parvo and adenovirus. Okay, even though we identified that there was no placentomegaly, there was no intrahepatic or intracranial calcification was there, and no obvious that sort of an history that is coming straight from the mother that was suggestive of any viral infections outrightly. But she definitely have had some gastroenteritis, and therefore our suspicion was towards the Coxsackie B19, right? So, meaning thereby that there could be a variety of viral infections that can pass on from the mother to the baby, and therefore they can lead to this globular cardiac hypertrophy. And the Coxsackie B19, CMV, parvovirus, and the adenovirus are the commonest ones, right? And and so meaning thereby that this viral infection at such an early stage can have different manifestations, and therefore the globular cardiac hypertrophy was there, and therefore that raised the suspicion that probably we are dealing with something with an infective etiology to the fetus, and therefore that is putting up the impairment onto the fetal growth, right? So this is our hunch. As we've asked for some blood investigations from the mother, we can ask for an IgG and IgM for a Coxsackie B19 as well as for CMV. Definitely, these are the indirect reasons, indirect sort of an investigations to the fetus through the mother. That probably, if it turns out to be positive, then probably our suspicion is being sort of supported. But in that case also, we would have asked her to do an invasive testing for those the PCR for those infections as well as for some chromosomal abnormalities, right? But why would a chromosomal abnormality would have a globular cardiac hypertrophy, and therefore the fetal restriction would be there? Even though this could be genetic event, but probably our whole suspicion in the first index case is towards the infective. So the infective etiology, and therefore we are having this sort of a globular cardiac hypertrophy, which is HCM, and therefore there could be some issues regarding the growth of the baby. We've identified that the umbilical arteries and the uterine arteries are absolutely good, and that the flows are absolutely fine. So what we believe is this, that within the coming 3 weeks or so, the baby should be in a position to clear out that infection, and therefore baby might come out of that sort of an infective sort of an milieu, and therefore there can be some catch-up growth, or probably there could be some sequelae. So meaning thereby that probably we need to keep the baby and the mother under sort of an follow-up and a surveillance, right? But we believe that it should come out. So this one small finding of an hypertrophic cardiomyopathy to the fetus, and therefore that was the clinching sort of an finding that really led to and could have explained and could have prognosticated and triaged the fetus, and therefore looks reassuring. Thank you very much for your patience.